When you look at most medical interventions, there is often this implicit promise of like mechanical precision.
Right, yeah, like fixing a machine.
Exactly. An orthopedic surgeon puts a titanium pin in a fractured femur, the bone
Mhm.
stabilizes, and the problem is solved. The mechanics are visible and totally linear.
And that creates a huge sense of comfort, both for the clinician and for you, the patient. I mean, we heavily favor interventions that operate on a really clear cause and effect physical plane.
But stepping into the landscape of urology, and especially pelvic reconstruction, it shatters that illusion almost immediately.
Oh, absolutely. It's incredibly complex.
It really is. So welcome to today's deep dive. We are looking at a stack of incredibly dense source material today. Surgical meta-analyses, urodynamic profiles, animal model research, all to unpack a deeply frustrating medical paradox.
Yeah, this is a tough one.
Our mission today is to understand the risk of developing de novo, meaning new onset urge incontinence, or overactive bladder after undergoing a mid-urethral sling placement.
Right, for stress urinary incontinence.
Exactly. We want to know how a highly effective gold standard surgery that is designed to stop one type of urinary leakage can inadvertently manufacture a brand new, equally infuriating type of incontinence.
Because we're looking at the exact point where a mechanical solution collides with the neurological system. I mean, stress incontinence leaking when you cough, sneeze, or exercise that affects anywhere from 5 to 30% of women.
That's a massive portion of the population.
It is. And since 1996, the synthetic mid-urethral sling has been the gold standard fix, and it's incredibly successful at its primary job.
It just acts like a backboard, right?
Yeah, exactly. It provides a synthetic backboard of support under the urethra. So during a physical stress event like a cough, a laugh, heavy lifting, the urethra is compressed against that sling and the physical leak is blocked.
Right. Problem solved.
You'd think so. But the literature reveals a catch. In securing that physical blockade, the intervention can sometimes trigger a sudden, compelling, and just totally uncontrollable urge to urinate.
Which is wild. You undergo the procedure because you leak during a deadlift, and you come out with a bladder that frantically spasms and like commands you to find a bathroom immediately.
It's a very difficult outcome for patients to process.
I bet. It feels somewhat akin to fixing a leaky faucet in an old house, only to have the sudden change in water pressure cause the pipes behind the drywall to start violently shuddering.
That is actually a really perfect analogy for what's happening physiologically.
Well, before we look at the mechanism behind that shuddering,
Yeah.
we really need to quantify the risk. Because if you are a patient parsing the medical literature, the data on this complication is shockingly volatile.
It's all over the map.
Literally, you can find peer-reviewed studies claiming the incidence of de novo overactive bladder after sling surgery is 0%, or like 1.7%.
And then you turn the page,
Yeah, you turn the page to another cohort study that puts the risk at 38 or 42%.
which is completely unhelpful. That kind of statistical variance renders informed consent nearly impossible if you only look at isolated studies.
So why is it so scattered? Are doctors just bad at tracking it? Or are patients too embarrassed to report the new symptoms?
It's a mix. The gap usually stems from really heterogeneous study designs, a lack of standardized post-operative questionnaires, and just the difference between actively monitoring patients versus retrospectively looking at chart reviews. Plus, mild symptoms might just be underdiagnosed.
That makes sense.
Thankfully, our sources include a massive systematic review and meta-analysis designed to filter out that exact noise. Researchers aggregated 32 different studies encompassing over 3,100 patients.
Wow. Okay, so pooling that data gives us a much more stable baseline.
Exactly. The definitive takeaway for the overall incidence of de novo overactive bladder after these procedures sits at approximately 9%.
9%. Okay.
To be specific, it's 11.5% in non-randomized studies and 6.4% in randomized studies.
I'm assuming the non-randomized cohorts skew higher because of selection bias. Like surgeons are operating on more complex patients in the real world compared to a strict clinical trial.
Spot on. But relying on that 9% average gives us a very solid 1 in 10 risk factor to discuss with patients.
Right. So about 1 in 10.
But that figure encompasses a very tricky temporal factor. The onset of these urgency symptoms is not uniformly immediate.
Wait, really? It doesn't happen right when they wake up from surgery?
Not always. The literature reports patients developing severe urgency up to 4 years after the initial procedure.
4 years? How do they even link that back to the surgery?
It's insidious. The prevailing theory for that delayed onset involves the gradual proliferation of fibrosis. As the body mounts a foreign body response to the synthetic mesh over years, the evolving scar tissue can slowly alter the tension and angulation of the urethra.
And I guess add to that the fact that baseline overactive bladder naturally increases with age anyway, and untangling a surgical complication from just natural aging becomes incredibly complex.
Exactly. It's a diagnostic nightmare.
Okay, so if the data confirms that roughly 10% of these anatomically perfect surgical placements result in a misfiring bladder, the surgery isn't failing mechanically, right? It's failing neurologically.
Yes, that is the crucial distinction.
So what is actually going wrong inside the body? The sources lean heavily on animal models to explain this malfunction, and they point to mild bladder outlet obstruction as the primary driver.
Right. Basically, if the sling is placed just a millimeter too tightly, it creates a subtle chronic roadblock for the urine.
Going back to the garden hose analogy, if you put a kink in the hose to stop a drip, the pressure builds up backward into the system.
Exactly. And the pump, in this case, the detrusor muscle of the bladder, has to drastically increase its exertion to push fluid past that microscopic obstruction.
Causing the pump to work frantically and eventually spasm.
Right. When the detrusor operates under chronic high-pressure conditions, it undergoes pathological changes. The prolonged mechanical stretch induces localized hypoxia-oxygen starvation in the bladder wall.
Wow.
Yeah, and that triggers a cascade of cellular metabolic shifts. This ultimately leads to what we call myogenic denervation.
Meaning the physical pressure is literally crushing or starving the micronerve endings in the muscle wall.
Exactly. So rather than a plumbing issue, it's an electrical feedback loop breaking down. If you stretch copper wires too far, the conductivity degrades.
So the localized nerve damage in the bladder forces the surviving nerves to hyperproliferate their receptors, right? Like they're trying to capture whatever scrambled signals are still getting through.
You've got it. That hyperproliferation creates a hypersensitive environment. The brain and the bladder lose their synchronized signaling loop, and the detrusor muscle becomes radically overactive, contracting involuntarily at low volumes.
Just because the receptor density is now completely out of balance.
Yes. But tension and obstruction are not the only pathways to this denervation. The literature outlines two other major mechanisms.
Right, the dissection and the irritation theories.
Exactly. First, direct surgical trauma. Creating the pathway for the sling requires dissecting through the vaginal epithelium and endopelvic fascia.
Which is heavily embedded with the delicate autonomic nerves that supply the bladder, right?
Highly embedded. Even a meticulous dissection risks stretching, thermal injury from cautery, or just direct transection of those microscopic pathways.
And the third theory totally abandons the mechanical and surgical trauma, focusing just on the material itself.
Right, the synthetic mesh tape. The sling relies on polypropylene. For a subset of patients, having that specific polymer resting adjacent to the highly innervated bladder neck triggers a chronic, low-grade inflammatory cascade.
So it basically just acts as a foreign irritant to the bladder neck, provoking spasms.
Exactly. The localized immune response acts as a constant chemical irritant to the nerve endings.
Okay, so we have three distinct vectors: mechanical obstruction, direct nerve disruption, and chemical irritation. If we know those causes, can doctors predict who is most likely to suffer from this before they even operate?
They can certainly identify high-risk profiles. Patients at higher risk tend to be of older age, have a higher BMI, or have diabetes.
And the sources suggest the diabetes link is due to diabetic neuropathy, right? Systematically damaging peripheral nerves.
Precisely. The nerves controlling bladder compliance and sensation are likely already functioning at a deficit. Subjecting an already compromised neural network to added surgical trauma is going to push that system over the edge much faster.
That makes total sense. And prior surgeries are a huge red flag too, especially previous incontinence surgeries or pelvic organ prolapse repairs.
Yes, absolutely. Prior surgeries guarantee the presence of altered anatomy and mature scar tissue. Navigating through that for a secondary sling placement requires a much more aggressive dissection.
Exponentially increasing the risk of damaging whatever autonomic nerve fibers are left.
Right. But there is another fascinating concept in the sources that challenges the whole de novo classification entirely: the unmasking phenomenon.
Yes, this part was wild. The hypothesis is that the overactive bladder isn't actually a new complication generated by the surgery at all.
Right. It's a pre-existing condition that was hidden by the severe stress incontinence.
Basically, the physical leak was acting as a pressure release valve. The bladder never had a chance to fill up completely, so it never reached a capacity high enough to trigger the spasm.
Exactly. Once the surgeon successfully implants the sling and fixes the leak, the bladder is finally forced to store normal, larger volumes of urine.
Which then unmasks the overactive bladder issue that was there all along.
It's a very real phenomenon.
But wait, I have to push back on this, because to a patient sitting in a post-op consultation, unmasking sounds suspiciously like a convenient excuse for a surgeon to say, hey, it's not my fault, you already have this problem.
Oh, it absolutely sounds dismissive. That skepticism is completely valid. But the preoperative urodynamic data robustly supports the unmasking theory. Because urodynamic testing relies on filling the bladder artificially with a catheter while measuring pressure gradients, researchers can look back at the pre-op data of patients who eventually developed post-op urge.
So what do they find?
They frequently find that preoperative detrusor overactivity and low bladder capacity were already documented on the charts. The bladder was demonstrably twitchy before the scalpel ever touched the skin.
Wow. So the sling merely changed the anatomical environment, allowing that hidden problem to become clinically symptomatic.
Exactly, which really highlights the absolute necessity of rigorous preoperative urodynamic testing.
Okay, so since patient history and anatomy play a massive role, the next logical question for a patient would be, can I avoid this by choosing a different type of sling or surgical technique?
It's a great question. There are multiple synthetic options out there.
Right, like transobturator tapes, TOTs, retropubic tapes, TVTs, and single incision mini slings. You'd logically deduce that the mini sling, which uses way less mesh and needs less dissection, would be the safest, right?
You would think so, but the meta-analysis completely upends that assumption. Statistically, it doesn't matter.
Really? No difference at all?
The variance is negligible. The meta-analysis revealed no significant differences in de novo OAB rates between the synthetic types. It's 9.7% for mini slings, 11.2% for TVTO, 8.7 for TOT, and 9.8 for TVTs.
That is wild. The amount of mesh and the entry point just don't correlate to a drop in urgency.
Right. It suggests the complication is driven by the vector of tension at the critical suburethral compression point rather than the total surface area of the plastic implanted.
The irritation and obstruction are happening at the exact millimeter where the sling meets the urethra.
Precisely.
What about avoiding synthetic mesh altogether? Given all the recent FDA warnings, a lot of patients ask about the autologous rectus pascha pubovaginal sling using their own tissue.
It's a common alternative, and it absolutely eliminates the risk of synthetic mesh erosion, which is a catastrophic complication.
But does it stop the overactive bladder risk?
Actually, no. The sources show the autologous sling still carries a risk of de novo urgency around 15 to 20% in one major study.
Wait, 15 to 20? That's higher than the synthetic mesh.
It is. The autologous fascia is typically secured as a true bladder neck sling rather than at the mid-urethra, and the
Right.
bladder neck is just densely packed with autonomic nerves.
Ah. And I'm assuming tensioning your own tissue is harder than using a standardized kit.
Much harder. Tensioning an autologous sling is highly subjective and technique dependent. It's primarily linked to an overtight technique. Plus, it's frequently used in patients who have had previous POP repairs, so their neural reserve is already depleted.
Okay, so knowing the risks and knowing that literally no sling is 100% immune to this complication, what happens when a patient wakes up with de novo OAB? How do we fix it?
The most critical rule from the text is this. Because of the temporal relationship to the surgery, doctors should always assume the cause is a surgical obstruction until proven otherwise.
Right, assume the plumbing is blocked before you blame the software. So what's the treatment ladder? Step one, I assume, is ruling out the basics.
Yes. Step one is ruling out basic complications like urinary tract infections or bladder perforations. If a trocar inadvertently perforated the bladder during placement, that causes profound localized inflammation and urgency. We use cystoscopy to check that.
Okay, so if the anatomy is intact, what's step two?
Step two is identifying a structural obstruction. If the bladder is generating massive pressure but failing to empty efficiently against the sling, surgical intervention is required.
Meaning you have to go back in and literally unkink the system.
Exactly. That could be a sling incision to release the tension, a full urethrolysis to dissect the urethra away from scar tissue, or tape shortening.
Removing that physical pressure stops the hypoxic strain on the muscle, hopefully letting the nerves recover. But what if it's not obstructed? What if it's step three?
Step three is when it's considered idiopathic. There's no clear physical obstruction, but the pathological spasms persist. The hardware works, but the software is scrambled. At that point, you treat it like standard OAB.
So behavioral therapy first.
Yes, behavioral therapy and fluid management,
Yeah.
followed by medications, typically antimuscarinics or beta agonists.
Because those intervene directly in that hyperproliferated receptor environment we talked about,
Right.
forcing the muscle to relax.
Exactly. And finally, if medications fail, we escalate to third-line therapies. That means Botox injections directly into the bladder to paralyze the hyperactive nerve terminals, or sacral neuromodulation.
Which is basically a pacemaker for your bladder, right? Modulating the nerve signals.
Exactly right.
Man, that is a phenomenal escalation of intervention for a patient whose initial goal was simply to stop leaking when they sneeze.
It really is. And I should briefly touch on what happens if the first sling fails entirely and second-line surgery is needed for the stress incontinence.
Right, because if you had to cut the sling to relieve the obstruction, the physical leak comes back.
Exactly. Options then include a repeat synthetic MUS, autologous slings, or a Birch Colpo suspension. Though the sources specifically warn against the Birch procedure if the patient has had 2 or more prior anti-incontinence operations.
Because the cumulative scarring just obliterates the tissue planes.
Exactly.
So, to summarize this whole journey for you listening, mid-urethral slings are highly successful, but the human body is deeply, deeply interconnected. Fixing a mechanical leak carries roughly a 9% risk of triggering a neurological urgency.
And that urgency is driven by either obstruction, nerve disruption, mesh irritation, or the unmasking of a hidden condition.
It perfectly illustrates how wild our anatomy is. We tend to view our bodies as plumbing a pipe leak, so we patch it. But the bladder isn't just a tank.
No, it is a highly sensitive organ in constant communication with the brain and nervous system.
Which leaves us with a final thought for you to ponder. If simply tightening a pipe in the pelvis can completely rewire how the brain receives signals of urgency, how much of our basic bodily functions are driven by pure mechanics? And how much by a complex, fragile neural feedback loop that we barely understand?
Think about massive hernia repairs with sheets of mesh or joint replacements. Are they really just mechanical fixes?
Or are they secretly manipulating our neural software? Something to consider the next time you think of the human body as just a simple machine.